And first off, I wanted to thank Dr. Hanau and the Heart Institute for letting me speak today. This is something I'm passionate about, saving limbs, saving lives, and I think this is the perfect platform to get something like this started. Fairly new practitioner, I'm not even out of residency 3 years, but have kind of found a niche in this type of work. So as an overview today, I'm going to talk first off about preventing these ulcers before they start, how you guys can educate your patients to prevent this catastrophic progression, review a little bit about limb salvage preservation, and then kind of differentiating between minor amputations and major amputations. So this would be my dream, to stop every wound before they start, but a lot of us would be out of a job. So, when I see a patient for the first time, I'm going to do a really comprehensive foot and ankle exam. That's my specialty. That's kind of where I stay. Looking at the skin for hot spots. Do they have calluses? Do they have abrasions or lesions? Are they neuropathic? Checking the monofilament. Because we know if they have neuropathy, they're going to be at an increased likelihood of getting these wounds. Checking their musculoskeletal deformities. Do they have a bunion leading to a problem? Do they have a hammer toe, a flat foot? Any of those things. And of course, checking their pulses. And I've grown a little bit more to correcting the deformity before it even becomes a problem. This is one of the patients I met early on. She had a bad bunion on her right foot. I ended up having to take that first toe off. She had osteomyelitis, gangrene, and unfortunately I met her at this stage too late. Once we had gotten the right foot taken care of, I went ahead and repaired that bunion on the left foot so we didn't go down that same path. And with the help of diabetic shoes, routine appointments, she's remained ulcer-free. I give my diabetic patients homework. I said, hey, this is your checklist. This is what you need to do. You need to be an active part of your care. You want to keep your feet clean. You want to keep them dry. If it's dry, you want them to put lotion on. If they're too moist, kind of the opposite. I have them inspect their feet daily. If they can't do it, get a mirror, put it under their, slide it under their feet to check, or have a family member, a spouse, checking their feet. Before they put their shoes on, I want them to stick their hand into their shoe to feel around. Make sure there's not rocks and pebbles. I know it's kind of hard to see, but right here is a staple sticking up into their shoe. This is a diabetic shoe, yay, but they're still not checking their shoes. I recommend that they wear clean white socks. Not because I like white, but just because if they're going to get drainage, if they're going to get bleeding from a wound, they might notice it on their socks before they're going to notice it on their feet if they have that neuropathy. Again, watching for hot and cold, those temperature gradients. They have autonomic neuropathy as well. Their body's not going to have that thermoregulation that the rest of us do. So if they're soaking their feet, I tell them, just like a baby, you're going to stick your elbow in, check the water temperature before you put your feet in. Same thing with ice packs. They can get a freezer burn just as easily. And keeping their shoes maintained. And, Medicare has really helped us. Sometimes we get some headaches from all the paperwork, but they've come up with this therapeutic shoe bill. Our diabetic patients that are at risk with a previous amputation or an ulcer can qualify to get special shoe gear, special inserts to help prevent this breakdown. And again, you never stop educating. Never ever. Don't smoke. Makes your PVD worse. Don't drink alcohol. Makes your neuropathy worse. Same thing with the heating pads. We never want these patients to go barefoot, even at home. I have them get a pair of Crocs or get a pair of slippers, something with a little bit of a sole that's going to prevent injury to their feet. I never want them cutting their corns and calluses. And again, some of these products, these corn removers, can turn into an issue. This patient of mine put, a corn remover, salicylic acid, on their corn, and it turns into this huge blistering mess on the bottom of their foot. So, these patients with the neuropathy, they can't tell that corn remover has gone too deep and caused a wound. This is something I've also adopted. I always look at both feet. If they're diabetic or they're at risk, every time, both shoes off. My medical assistants are kind of trained to do this. This is a patient came in for heel pain. Standard thing we see, plantar fasciitis. But we took off the other shoe, and here's a little shard of glass in the other foot that we wouldn't have found if we didn't tell him to take off his other shoe. And always re-educating patients. Toenails, something as a podiatrist we see every day. You know, these are some of the extremes, but they do walk through our doors. You know, treating the nail fungus, treating them routinely. You know, getting rid of an ingrown toenail before it becomes an issue is where we want to start. You know, in foot care, us as podiatrists, we're trying to see these patients every 2 to 3 months to trim their nails, to watch for issues. You know, and again, having a long toenail or an ingrown toenail, I see tons of wounds that way, and this is something completely preventable. You can catch the problems before they start. And I encourage you to check their feet if they're coming in just for a history and physical or for anything like that. And we're sometimes the first line of defense against things like this. I'm sometimes seeing patients more than they're seeing their primary care. So we want to catch this. And patients are comfortable. They're getting their nails trimmed. They're feeling good. They're out walking, and they're being healthier. And again, an ingrown toenail gone wrong. This patient has rheumatoid arthritis, is on immunosuppressants, you know, had an ingrown toenail. Unfortunately, that went to osteomyelitis, and she lost her toe over something as silly as an ingrown toenail. So the technical definition of limb salvage, you know, is an amputation at the show part joint. And what you're doing, you're leaving the talus bone, you're leaving the calcaneus bone. You're giving them a limb that is equal in length to the other side. You can kind of see that designated here. Anything distal to this is considered a minor amputation. Anything proximal to that is considered a major amputation. But looking at limb salvage as a whole, limb preservation, there's so many other facets that go into this. You know, have we reduced their pain with our treatment? You know, a lot of time that ischemic pain that they're having in their toes, you know, if I do an amputation, I can improve their pain and improve their function. You know, can the patient ambulate? You know, that kind of comes in, is that residual foot functional? You know, that's a goal. I can do surgery all day long, but if that patient is not going to use that foot, I don't think it's that successful. You know, and have we gotten rid of the infection, the necrosis? Am I giving them something that's not going to keep coming back time after time? And has their quality of life been changed? So other things I look at, I try not to leave, you know, what we call biomechanical issues. Yes, maybe I can save one toe in the center. Am I a hero for doing that? No, because this patient's going to be back in my door with another wound, you know, down the road. You want to use your devices to offload. You want to get everybody involved, their internal medicine family doctor for sugar control. You want to address their social issues. You know, if you're going to do a procedure, can this patient go home, or do they need to go to a skilled facility? Do I need home health care? You know, what else can I add for this patient's success? And then timing of their procedure. Is it going to be a staged procedure, a one and done procedure? All those things come into effect. And getting your labs, your imaging is all part of that process. You know, shoes and bracing, you know, as podiatrists, this is kind of one of our things that we stress. This is a patient of mine on the right here. She had a transmetatarsal amputation, and it was a very proximal, very short foot. And she comes to me, she says, you know, my surgery is great, but I can't balance. Every time I lean forward, you know, her toes aren't there to catch her. So we put in a carbon fiber plate in her shoe, and then this anterior kind of crest on her tibia to kind of balance that force. And believe it or not, these are diabetic shoes. They've come a long way. They look like normal shoes now. People don't have that social stigma of the, you know, Herman Munster shoe. They can get shoes that are fairly normal and can kind of fit in. We get them kind of, this is a toe filler. So when they're in their shoe, their foot's not pistoning back and forth. You're not getting that friction. It's stabilized. And this, you know, this is a Crow, a Charcot restraint orthotic walker. It's kind of like a total contact cast. It's giant and it's heavy, but if your patients are compliant in wearing this, we can stop a lot of wounds and prevent a lot of surgery with this type of stuff. You know, again, looking at the patient as a whole, I feel nutrition is very important. You know, looking at their, again, overall picture, not just the wound, But, I could throw, $1 million, fairy dust, whatever, at a wound. It's not going to heal if they don't have that nutritional power to heal the wound. So getting a nutritionalist involved, getting a dietitian, getting their PCP involved to get this going. And again, what we've kind of been talking about are ischemic issues. You need to be alert. If you can't palpate pulses, if you have an ulcer that's not healing, send them to get baseline studies, refer them out early. I've carried a handheld Doppler in my office. If I can't feel the pulses, I'm Dopplering them. If I can't Doppler them, they're on to the next, onto the next provider that can give them what they need. Because one toe turns to multiple toes, turns to an amputation so quickly, and sometimes there's no stopping it. I'd rather catch it when it's here and just do a toe amputation instead of cutting off half their foot. So transmetatarsal amputation, if I can't save that digital amputation, this is kind of my next go-to. It's very functional, it's stable, it's braceable, and if we can get it done right, they stop at this level. A lot of times we do have to do an Achilles lengthening, just since we've lost some of that angle on the foot. But if I can stop it here, I'm happy. Something as silly as a blister on the toe from a poor fitting pair of shoes turns to gangrene, turns to a TMA. And I see this over and over and over. And stopping it before it starts would really save everybody a lot of trouble. Is a transmetatarsal amputation bad? I had to look at this. What is their 30-day mortality? And kind of looking back at my studies, in my cases, it's similar. 30-day mortality is about 3% for a TMA, but double that for a BKA, double that for an AKA. So I want to try to keep it at that level if I can. Trouble is, if my TMA gets too short, again, we're losing some of those muscles. We're losing our everters, our lateral muscles in our foot, our peroneal tendons. So if you lose the bases of the metatarsals, your foot is going to turn into a varus, or inverted position. And with neuropathy, we then get these wounds on the lateral aspect of their foot. Sometimes that does require tendon transfers or fusion surgeries to give them a stable foot. And again, a Chopard amputation, I talked about this a little bit earlier. It's a little stump. It's very small, but these patients just need a little bit to transfer to their wheelchair or to get to the bathroom. Again, the muscles that you lose kind of come into this. You've lost everything but your Achilles at this point. So either doing an Achilles tenotomy or an ankle fusion is sometimes needed, because if not, that stump's going to plantar flex and you're going to get a heel ulcer. And again, the heel ulcers, this is one of my least favorite things to treat, just because even in a normal perfused person, this area is pretty dysvascular. And doing a partial calcanectomy, you're losing the Achilles. You always have to brace these patients, but using this is a Prefo or a heel protector boot can be helpful in getting these to heal. And for completeness sake, I put in a sign amputation. That's an ankle amputation or a transtibial amputation, or excuse me, a distal tibia at the ankle joint. But in New Mexico, our scope of practice limits a podiatrist. We're not able to do this level of amputation, but there are studies that show this can be functional. So moving more into the major amputations, this was touched on earlier. We are making an impact. We are decreasing these major amputations. Looking at Medicare data from 2000 to 2010, we've stopped, the progression of these amputations by about 17,000, which is really good. Not all the way there yet, but definitely getting better. Oops. Oh, sorry, it didn't come out quite well. But why are we avoiding these? We want to avoid these major amputations because we know the 5-year mortality is very high. A BKA average survival is a little more than 4 years. An AKA, a little less than 2 years. And it's not the amputation that's killing these patients, it's more the comorbidities. Your diabetes, your peripheral arterial disease, your coronary artery disease. But, BKA is kind of right in line with all those things. So looking at that, your energy expenditure does go up as your amputation goes up. This is a classic study from Waters who looked at oxygen consumption and gait velocity on traumatic and vascular amputees. Same thing with velocity. Your velocity goes down, your gait speed goes down, but your oxygen consumption goes up. So how can you kind of estimate to see which patients will be functional, which ones will walk? I had a good chance yesterday to talk to some of the prosthetists from Hanger. But if your patient can walk with crutches, kind of hopping along, they can essentially be a functional ambulator with a higher amputation. That being said, how many of these patients do walk? BKAs, AKAs, it's only about 25% will be a functional walker. That means walking with their brace out in the community. BKAs a little bit better, 75%. And almost half of people with an AKA never use their prosthesis. So definitely want to stay away from this if we can. And this is a large study of almost 500 patients. They asked them to rank, what do you fear most with your diabetes? What bothers you? BKA was number 2, above death, above dialysis, above a foot infection. The only thing it was behind was blindness. So these patients really have a stigma and a fear about this amputation. So that's where we want to kind of stop where it starts. I often ask, I work with these patients a lot, and when we come to this decision, they ask, is my life over with an amputation? And it's not a decision to be made lightly. You should have, multiple family members there, all discussing it, and the patient has to be ready. Unless it is a life-threatening infection, a lot of these can be plans. So talking to the patient, educating the patient is number 1. Some patients do feel better after an amputation. That necrosis is gone, that nidus of infection is gone, and they feel better. And looking at more at the quality of life studies, if that patient can make it to 1 year after surgery, their mental and physical component scales are equal or better to that before surgery. So briefly, I wanted to talk about, this was a study that got started as I was finishing my residency. The lead author, Dr. Lukic, he's a foot and ankle orthopedic who does a lot of limb salvage. So he looked at almost 100 consecutive BKAs in patients with diabetes. And this was everything from, vascular ulcers to Charcot to neuropathic diabetic foot infections, and came up with some good data. I thought this was interesting because this kind of correlates to me. They were doing an average of 3.5 procedures before going on to a BKA. I kind of joke with my patients, 3 strikes and you're out. If I've done 3 procedures on your foot, it's not likely there's going to be a lot of soft tissue coverage left. So I feel like I'm hopefully on the average on that point. But, we always do what it takes. I don't say, every time 3 is the number. But, that's kind of a good ballpark that I try to hit. 28% of patients, almost 30% of patients died, and it was a minimum 2-year follow-up. Having end-stage renal disease increased the risk. These patients with their comorbidities, the end-stage disease, it really is a factor of the whole patient. So if they're on dialysis, they had an increased risk of mortality. And kind of on average here, 62% were able to be functional ambulators with their prosthetic, and 3 of them were converted to a higher amputation. But kind of the real take-home point was if you have a major amputation on one side, 40% of patients had an issue on the other side. Whether it was a BKA, a toe ulcer, this guy's lost a toe here, it's hard to see, but that other limb is never out of the woods either, even when you have a BKA. So goals, stop the wounds before they start, never stop educating, and definitely have a team approach, what we're kind of beating into everybody today. So I appreciate you guys letting me talk, and I guess we'll do questions here in a second.